Good morning, everyone. Good morning. So, I have one disclosure, and it's from my mother. And that is that I'm not a proper doctor. Unlike all the other people that we've heard from today. My lab treats small white animals in mice, which I'll tell you about today. And I'm representative of a group of basic melanoma researchers here, including my esteemed colleague, Dr. Holman back there, who's not speaking today, but is here to support the melanoma research program. I came here about 4 years ago from the University of California in San Francisco, and I came here in part because the ACI has the most remarkable research in melanoma, from prevention research, the basic laboratories research that I'm going to talk about, to clinicians that are treating melanoma at early stage, like Doug, or advanced stage, like Wen, and John, and Ken, and Tanya, that we've heard from today. And then taking and running clinical trials as well. And Ken nicely illuminated on that previous slide. HCI makes an incredible contribution nationally and internationally to melanoma clinical trials. And that's how we work out whether the things that we do in the lab ultimately have value in treating patients. So some of the stuff I'm going to talk about, you may have heard, and this will be maybe a good reminder of the fact that it used to be that melanoma was a single disease, and we didn't really understand much about the subsets of melanoma. But with the incredible advances in DNA sequencing technology, where we can sequence a whole human genome in 2 days for about $300, people have applied that technology to now sequencing cancers. It's an interesting thing to think about. When the first human genome was sequenced, it cost about $3 billion. And when now we sequence a whole human genome, it costs about $300. To put that into terms that some of you may appreciate, if you're a car buff, it would be like buying a $100,000 top-of-the-line Porsche in 1992 and buying it now for a penny. That's the change in how much the technology has moved forward, how fast, cheap, and accessible that technology is. It is, well, I'm talking about a $100,000 Porsche that I did not buy back in 1990. And so, the sequencing technologies that we now have are incredibly powerful to be able to allow us to delve deeper into the world of disease and understand things that we previously never really fully appreciated. And what we now understand is that melanoma can be subdivided into pretty much 4 different groups based on the genetics of the disease. Some melanomas have a mutation in a gene called BRAF. Some melanomas have a mutation in a gene called NRAS. They're closely related in the cellular signaling pathway. Some melanomas have a mutation in a gene called NF1. And then the last group are what we call triple wild type, and they don't have an obvious mutation in any one of these 3 genes. And these gene mutations have an enormous role, an enormous importance in the context of how melanoma is treated. So when we think about the sort of therapies that can be applied to these different types of melanoma, the obvious ones that you know about are immunotherapy, targeted therapy that targets the specific genetics. So immunotherapy can be applied across most of these subsets. The targeted therapies are tailored usually to this specific subset, the BRAF subset. Virotherapy, which is the use of viruses to try and kill melanoma. And then finally, conventional chemotherapy. Now, there are other types of therapy, but these I think are probably the 4 major ones that are currently used. And when we think about this, what we're interested in is the best possible initial response, how to take a person who's got a substantial disease burden and actually make it go away. We think about the longest possible response, and of course in a perfect world, the longest possible response is forever, and then a complete cure. And then we also think about safety and tolerability. In other words, there's no point giving you a therapy that will cure your melanoma if it kills you or causes some other highly deleterious side effect that's going to have an adverse effect on your life. So we care about all of these things. And then I should just refer back to Ken's talk. In certain circumstances, in adjuvant chemotherapy, where you're treating a patient who's had surgery and has no evidence of disease, what you're trying to do is to stop the disease coming back. Now, my lab has been interested for a number of years in this particular subset of cancer, melanoma, driven by a gene called BRAF. Now, BRAF is an enzyme, and it takes the energy of ATP and takes the phosphate from ATP and puts it onto another set of molecules. And so doing, now activates the cell's proliferation machinery and makes the cell divide in an inappropriate and uncontrolled fashion. And that's at least partly the basis of why BRAF mutation causes melanoma and also other cancers. The BRAF is not restricted to melanoma. And so many years ago, a number of companies have come up with small molecules, these are drugs, now all approved by the FDA, that can get into the BRAF enzyme and gum up the works. So what you're seeing here is a slightly different way of illuminating the structure of BRAF. And then this is a representative of this class of drugs. And you can see here that these drugs get in here to the enzyme. They actually prevent the binding of the ATP molecule that I told you was essential for the function of BRAF. And by jamming themselves into this catalytic cleft, stops BRAF from having its ability to promote cancer growth. Now, just the first signs that these drugs might actually work were published probably in the latter part of 2007, 2008, 2009. The first drug in this class was approved in 2011. So we're talking about therapies that are really pretty new. So this speaks into the thing about the issue about the deepest possible response. So this patient, you don't need to be a physician to see that this patient is not well. The patient has widely advanced metastatic melanoma, and we know that this patient from a genetic test has a mutation in BRAF. So this patient was enrolled on a clinical trial, and you can see that within the space of about 3 months, this patient has shown a dramatic response. So that idea of best initial response is being satisfied, at least partly here. And I should say that not all of the lesions are going away. But you can, again, don't have to be a physician to tell that this patient has gotten substantially better. So that told us then that these patients that have these BRAF mutations, that the BRAF is important for the maintenance of the disease, because if you give that patient a drug, and this patient was one of hundreds on clinical trials, you could get these remarkable responses. But the challenge was that a few short months after this initial response, was that the disease came back in a drug-resistant fashion. And at that point, the drug stopped working. So this tells us that in BRAF mutant melanoma, BRAF is a good target, but in order to be able to really give you the longest possible response, that you need to try and prevent this onset of drug resistance. Now, I don't know if there's any circuit designers or electricians in the audience, but this is a little map of the intracellular wiring diagram of how BRAF does its business. This is the outside of the cell, this is the inside of the cell, this is the nucleus where the information is decoded and turned into a biological program. And here's BRAF right here. It lives in the middle of the cell, and it sends signals that promote the growth of the cell. And the reason that we have BRAF in the first place is because we use BRAF, or our cells use BRAF, for normal mechanisms of development and tissue homeostasis, wound healing, and many other processes. But it's when BRAF gets mutated and jammed in the on switch, like sticking a brick on your accelerator in your car, now you can't stop it unless you find a way to gum up the works. But also importantly, the mechanisms of resistance that give rise to those drug-resistant disease, basically the cell finds a way to circumvent this and turn this pathway back on again. And there have been numerous papers over many years documenting the mechanisms of resistance to these BRAF inhibitors. So what we now want to do is to take this information and try and turn it into clever ways to stop the onset of growth resistance. So how do we do that in the lab? So, as I mentioned, all my patients are covered in fur. I've got 4 legs and a tail. And in this particular case, melanoma. This mouse has been genetically engineered using techniques that were actually pioneered here at the University of Utah by Mario Pepetti. Some of you may have even driven on Mario Pepetti Drive on your way to get here. And the reason he has a street named after him is because he won the Nobel Prize for the invention of these incredibly sophisticated techniques that allow us to manipulate mice to understand how genes contribute to normal development and how they also contribute to disease. And so we have a variety of different clever strategies that allow us to generate mice that have melanoma. In this particular case, this is a BRAF mutant melanoma that shares many of the characteristics of BRAF mutant melanomas that we're targeting patients. The nice thing about this type of experimental paradigm is that we can actually do this quickly, and we can do it in very large numbers of mice. So if we want to do, say, for example, a clinical or preclinical trial where we compare the continuous dosing of a drug versus another drug versus combination therapy versus an intermittent dosing versus an alternating dosing schedule to say what's the very best drug regimen that we could give a BRAF mutant melanoma to prevent it from coming back. We can do that in the mouse, and we can do it fairly quickly, and that's one of the things that we've been doing for quite some time. I've been doing it in looking at BRAF mutant melanoma, looking at BRAF itself. Jerry has been looking at another enzyme targeting system in the cell, which is the PI3K pathway. And this just shows you one example of the sorts of results that you can get from this. So in this case, the mice were treated with a single drug from a company called Genentech, where you can see that the melanomas initially shrank, but then they came back in this drug-resistant state. But by combining a second drug that targets the pathway that Sherry Platt is particularly interested in with drug number 1, we get roughly the same level of shrinkage, but now we can actually keep the mice in melanoma regression for a longer period of time. So this is the sort of data that we would then take to Ken or Wen or other people in our melanoma community and say, we have evidence that in the preclinical situation that we can prevent the onset of drug resistance. And now, is it possible that we could run a clinical, that you could run a clinical trial, and again, I'm not a proper doctor, to test this in human beings. Now, I'm going to turn and tell you a story that actually is fairly new. And that focus, so the sorts of research that we do a lot is to address questions about different dosing regimens, about combination therapy. You've heard from Wen about the power of immunotherapy. The question is, how do we combine immunotherapies? How do we combine immunotherapies with viruses? Or how do we combine them with pathway targeted agents? Again, those are things that would take a very long time to do in clinical trials. But if we can actually narrow down the possible combinations in preclinical models, we can actually design smarter clinical trials that make you more likely to be effective. And then finally, safety and tolerability. But the one thing I will say is it's actually quite difficult to predict safety and tolerability from mice experiments, because as it turns out, mice are not just small, furry human beings. And the physiology of a mouse and the toxicity that one sees with drugs in a mouse are not really highly predictable. So one of the things that we've become interested in is this subset of melanomas driven by a molecule called RAS. And the story I'm going to tell you today is related to work that we've been doing in lung cancer and pancreas cancer and in melanoma. So one of the things that we discovered is that when we target that MAP kinase pathway that BRAF activates in the NRAS subset of melanoma, we find that the cell adapts to that therapy in such a fashion that it doesn't kill the melanoma cell or the cancer cell. And the reason we think that happens is because these little red dots, these are what are called autophagic vesicles. Now that sounds like a very sophisticated thing, but what it really is the cell recycling its own internal components. Basically a recycling process to generate new metabolites that appears to play an important role in the resistance of these cells to this pathway targeted therapy. We then could take this into our experimental animal models and show that if we combine a drug that targets the MAP kinase pathway with a separate drug that blocks this cannibalization process, this is a drug called hydroxychloroquine, that we can cause shrinkage of RAS-driven cancer. These are two different models. They have to be pancreatic cancer, but we've done this in melanoma as well. And not only that, the treatment with this combination is actually superior to the conventional standard of care that is given to patients that have pancreatic cancer. So what we found is, at least in this preclinical model system, that the combination of these two drugs was superior to the standard of care and made the tumor straight away. Now, we were in a unique situation when the young scientist in my lab who did this work, who was a medical oncologist as well as a scientist, was consulting with a 68-year-old man who was diagnosed in 2017 with pancreatic cancer. I want to play one-upmanship here, but in the pantheon of cancers at the moment, pancreas is probably one of the toughest diseases to treat. This patient had been heavily pre-treated with lots of different types of chemotherapy, and at the point where his best response to chemo was stable disease, and at the point that my colleague Connie Kinsey was consulting with this patient, the patient was complaining of pain in his abdomen, in the celiac plexus, which is usually a bad sign that the disease is coming back. There's a blood marker called CA19-9 that physicians use to measure the growth of pancreas cancer. And so in most of us, the CA19-9 pancreas cancer antigen is usually less than 50. And if it increases, it's usually a bad sign. So you can see here, the patient was diagnosed in February 2017. He got chemotherapy prior to a surgical resection, and then he got adjuvant chemotherapy after his surgery. And he stayed on that until such time that he had to stop it because his white blood cell count was diminishing because of the chemo. And you can see here that once that adjuvant therapy stopped, his CA19-9 blood marker began to increase. And the physicians recognized that this was a bad thing, and so gave him this combination of 3 chemotherapeutic drugs, and it had absolutely no effect. You can see the CA19-9 began to increase. And at this point here, the patient was facing end-of-life care. There was nothing more that our GI malignancies clinic could offer this patient. So we spoke to the patient and asked him if he was interested, and we showed him the data. He was a scientist, and so he recognized and could understand the data that we had in the laboratory. And said, we have 2 drugs, both of which are FDA approved, which have never been combined in people before. And it's based entirely on the sort of mouse experiments that I showed you. But if you're interested and willing to take a chance on this, we can get access to these drugs to you on a compassionate basis. And so he agreed to do so, and so we started out with full dose of this drug called trametinib and 400 milligrams per day of hydroxychloroquine. You can see here that the initial effect was no response. We then doubled the dose of the hydroxychloroquine, and again, not much happened, except for the fact that around about here, the patient said that the pain in his abdomen had gone away. And we were aiming ultimately to give him 1,200 milligrams of hydroxychloroquine every day. And when we hit that point, all of a sudden, his CA19-9 decreased from 33,000 to less than 1,000. And it did so over the course of about 6 to 8 weeks. Now, the CA19-9 is just a marker. It doesn't actually say necessarily that the tumors were getting smaller. So what we did was we then did CT imaging of this patient. And this was the patient at baseline when we began to treat him. And you can see all these shadows. This is his liver. And again, I should also say that I'm not a radiologist, so I'm kind of interpreting based on what I've been told. But I recognize a liver when I see one of these. And each of these shadows are metastatic lesions in the liver. So these are pancreas cancers that have metastasized from the pancreas and are now growing in the liver. And this is the reason why many patients die of pancreas cancer. They actually die because the liver gets taken over and it fails. And you can see here that on the 3rd of August, this patient, we could barely detect any evidence of those liver metastases. Now, I should say that, as we expected, the patient subsequently developed resistance to the therapy that we gave him. But nonetheless, we believe that we extended his life by about 6 months. And that patient, by volunteering effectively, he used to joke to us that he was effectively like a big mouse, and that he was the experimental tip of the spear, if you like, in terms of being the first person ever to receive this therapeutic intervention for gastroenteritis. Now, we are very familiar with this adage from Aristotle, the famous Greek philosopher, who said, "One swallow does not a summer make." And so the fact that one patient would respond, you might treat 50 or 100 or 1,000 more patients and never see another response like it. And so the only way we can work out whether this might turn into being a new therapy for patients is to do this in a clinical trial. And I'm happy to say that there are actually 2 clinical trials that have now been initiated. One is going on here at the Huntsman Cancer Institute, which is a combination of 2 drugs I mentioned, trametinib and hydroxychloroquine in patients with pancreatic cancer. And then a second trial in patients with NRAS-mutated melanoma is just about to initiate in France. The reason it's happening in France is because Dr. Amélie Beausclub, who is a French dermatologist, was doing her PhD in my lab here at HCI. And so she was contributing to this research as part of her PhD study. When she completed her PhD study, she then returned to France and proposed to do this clinical trial at University Hospital in Lyon. And we will know, hopefully, in the next 18 months to 2 years, whether this looks promising in melanoma as well as in pancreatic cancer. And so I think that hopefully illuminates how we go from very basic studies in the laboratory through studies in animal models, through, in this case, the use of a combination therapy in a single patient, and ultimately into a clinical trial that might help us then understand how we might be able to target some of these particularly difficult diseases to study. And then finally, one of the things that we're very excited about in our melanoma research community is that we are hosting here in Salt Lake City in November the 16th International Congress of the Society for Melanoma Research. This is the preeminent society for melanoma research in the world. And the conference is being organized by a cast of characters here from the Huntsman Cancer Institute, Ken, Sherry, myself. Nancy Leachman used to be here, and she went off to the Oregon Health Sciences University, and Jen Wargo, who is a melanoma surgeon, and Ashi Virana, who is at Johns Hopkins University. So with that, I'll be more than happy to answer any of your questions. Thanks very much.